Hi everyone, good evening. How are you all? I'm Dr. Sidharth Sethi and I'll be discussing the pediatrics part of the FMGE exam. Now, if you look at the exam, pediatrics was a very straightforward paper and it was all from whatever we teach regularly in our pediatrics classes. So I can tell you, if you read your notes, this would have been enough for your FMGE exam. I'll be just discussing questions and I can tell you there were more than 15 questions which came from pediatrics this year in the FMGE. So let's start and I'll be answering all your queries in the chat box. So you can write your queries in the chat box. I will answer all the queries. So the first question was a very straightforward question. What is a postterm neonate? And we have, multiple times told you in your classes. And this is in fact the first, when we start the class, this is the first thing I start in the class. What is a preterm? A baby less than 37 weeks. What is a term baby? Between 37 to 42 weeks is a term baby. Postterm is after 42 weeks of gestation. All of you are right? You can write in the chat box. So it was a straightforward question. Now let's take you to the next question. And many of the students told me that in fact there was a pedigree which came in this exam. And the pedigree was something like this. All the generations were affected. All the generations were affected. So all of you remember in our genetics class, we always talk about pedigrees and how to analyze that. I can tell you whenever you look at a pedigree, look at number one, whether all the generations are involved or not. Now in the pedigree which came in your exam, all the generations were involved. So it was dominant. Now males and females were equally involved. So this becomes autosomal. So this was the pedigree which came in your exam. Males and females were equally involved. All the generations were involved. Autosomal dominant. So remember, in recessive disorders, parents would be carriers. So they would look normal. Okay, so that's very important. Let's go further to the next question. So again, a straightforward question. Next question is also a very common question which we discuss in neonatology. The question is that number one, what do you think is the most important contraindication of breastfeeding? Is HIV? Let's start from herpes. Herpes is not a contraindication. Hepatitis B, C is not a contraindication. Now HIV, when we talk about HIV, remember in India, we give options to the patients. We give options, we give options like number one, you can think about in India, breastfeeding is not an absolute contraindication. While in the West, we do give them formula feeding. Now let's talk about galactosemia. And all of you should know, and we discussed this, that galactosemia is a metabolic disorder, an autosomal recessive disorder in which there is a block here. It is a deficiency of enzyme galactose 1-phosphate uridyl transferase. So remember, galactosemia is deficiency of enzyme galactose 1-phosphate uridyl transferase. Okay. So 95% is a deficiency here. So what accumulates in galactosemia is this galactose 1-phosphate. Now this galactose 1-phosphate is hepatotoxic. It causes liver failure. So remember this, because of a block here, there is liver failure in a neonate. And because of the accumulation, now galactitol increases. Now because of this accumulation, the baby gets cataract. So remember all of you, if you ever see a baby with liver failure, jaundice, bleeding, with cataract, think about galactosemia. So remember, galactosemia is an absolute contraindication of breast milk. It's an absolute contraindication of breast milk, and in these babies, we give them lactose-free milk. Okay? So we give them a soya-based milk instead of a lactose-based milk. So again, a straightforward question. Now next, again, whenever we talk about neonatology, we always start with neonatal resuscitation. So I've taken multiple sessions on neonatal resuscitation on the DAMS Club, on Facebook, in your classes. And you should all remember that in neonatal resuscitation, when we start bag and mask, remember we use room air. There's a lot of evidence now to use room air. So remember, number one point, remember, this point will also help you in your further exams. Whenever a baby is in apnea or gasping, remember, baby is in apnea or gasping after the initial steps, start him on positive pressure ventilation, which is bag and mask. Okay, so what is the first indication of positive pressure ventilation? I said apnea or gasping after the initial steps. Okay, number two, if heart rate is less than 100 after the initial steps, we start the baby on positive pressure ventilation, which is called bag and mask ventilation. So remember these two indications of bag and mask. Now remember, for positive pressure ventilation, for babies 35 weeks or more, we use room air. So now there's a lot of evidence that you do not need to give 100% oxygen, just room air. For babies less than 35 weeks, we use 21 to 30% oxygen. So remember, for term babies, for positive pressure ventilation, we use room air. We don't attach oxygen to the bag and mask. Let's go further. Now another question on neonatal resuscitation came, when do we start chest compressions? Now again, remember, in each and every class I told you, when do we start chest compressions? When heart rate is less than 60. So please remember, when heart rate is less than 60, after 30 seconds of bag and mask. So we start bag and mask. After 30 seconds of bag and mask, if heart rate is still less than 60, we start chest compressions. And now today, since we are all here, let us also remember 3 more points. Anyone, any questions in the chat box? I'll just straight away write in the chat box your answers to the queries. So when we start chest compressions, you intubate. And now is the point to add 100% oxygen. So now is the point to add 100% oxygen. You also at this point of time attach a umbilical venous catheter. Now you should know, where do we do chest compressions? Midway between the internipple line and the xiphoid process. So midway between the internipple line and the xiphoid process, midway is the compression area. So of course, you know, the answer was straightforward, heart rate less than 60. Despite 30 seconds of positive pressure ventilation. So how was it, all of you in the chat box? How was your paper? Easy? At least pediatrics part was straightforward, I can tell you. There were no, no rare questions to be asked. Now there was a simple question, when do we start breastfeeding in a newborn? Remember, we always say, and WHO always says, breastfeeding should be started within 1 hour, according to WHO. Within 1 hour or as soon as possible after birth. So can you just tell me the options which came in your exam? So I think they were within 1 hour, within 4 hours, within 24 hours. So it was not after, it was mostly within. So remember, WHO word is within 1 hour or as soon as possible. Now there was a chest x-ray like this. They said a baby is frothing, a baby has tachypnea. What is your diagnosis? All of you, anyone in the chat box? Diagnosis, I'll just zoom it for you. This was the x-ray which came in your exam. A tube was coiling in the upper pouch. So diagnosis, all of you? Of course, it was a tracheoesophageal fistula, a classic case of tracheoesophageal fistula. So all of you should remember, and I'm sure you all know this from our previous classes, that the most common tracheoesophageal fistula is type C, in which upper esophageal pouch is blind and the lower esophagus is joined to the trachea. Okay, so upper esophagus pouch is blind and the lower esophagus is joined to the trachea. So this baby, cannot swallow. So this baby is, dribbling saliva, dribbling milk. This baby gets pneumonia because aspirating the gastric juice, this baby gets pneumonia. Now, this gastric juice also goes to the, mouth, and this baby is frothing. So in fact, this was the question in your exam. A baby is having distress and frothing. What is your diagnosis? and they showed the X-ray. It was a classic case of tracheoesophageal fistula. Okay, it cannot be tetralogy of Fallot. It cannot be congenital hypertrophic pyloric stenosis. They have vomitings, but they do not have frothing from the mouth. That's a classic case which we see, every day of our lives. Anyone? Any doubts in the chat box? Let's go further. Now, there was a question on what should be the resuscitation fluid for SAM with shock and hypoglycemia. So they showed that there is a baby with severe acute malnutrition and this baby is in shock and hypoglycemia. Now, all of you, we have always discussed that, the fluid of choice for shock is always normal saline. Fluid of choice for shock is always normal saline. But for malnourished children, you cannot give them a lot of saline boluses because they can go into fluid overload. So for malnourished children, especially those with hypoglycemia, a better fluid would be Ringer lactate in 5% dextrose. Okay, so if this child was not hypoglycemic, I would mark Ringer lactate. If this child was a normal child, all of you remember in the chat box, if this child was a normal child, I will give him normal saline. Normal child which is not malnourished with shock, we give normal saline. SAM with shock, Ringer lactate. SAM with shock and hypoglycemia, Ringer lactate with 5% dextrose. Let's go further. And there was a very simple case of a fever with rash. And they showed that there is a child who has fever, rash, conjunctivitis. What is your diagnosis? Anyone? Anyone in the chat box? Yes, you're right. It was measles. So measles, remember, has a prodrome. Measles has a prodrome. So there's a fever, cough, coryza. After the prodrome, in your exam, they may ask you, what are Koplik spots? So after the prodrome, you see Koplik spots on the buccal mucosa. What are Koplik spots? They are blue-gray specks. Okay, so I'll just zoom it for you. Can you see the buccal mucosa of this child? Can you see some blue-gray specks on the buccal mucosa? Very important question for your exam. Koplik spots appear before the rash. Can you see cough, coryza appears before the rash? Look at this child. He looks so toxic, eyes are, watering. He has cough, coryza, conjunctivitis. So this is a typical case of measles. So remember, before the exanthematous phase, measles has ananthematous phase. And then they get a confluent rash. And all of you must have seen these rashes in your medical school. It's an erythematous maculopapular rash over the trunk, which is a confluent rash, which lasts for around 4 to 5 days, leaving behind desquamation. Remember, the desquamation spares the palms and soles. Okay, remember that. Roseola infantum is more of a, it's a viral illness, a slap cheek appearance. Chickenpox has vesicles, pustular rash on the trunk. Hand, foot and mouth, as it says, you see vesicles on the hand, foot and mouth. This baby is not able to drink water also. It's an infant. Okay, very common these days by Coxsackie virus. Now there was a question on short stature, and many of you mailed me that, sir, in fact in the question there was bone age was equal to the chronological age and height was just like his parents' height. So I'll tell you two things, important things. I'll show you a graph. On your screen is a graph of a child in the first 2 years and his adolescence. Now let's first look at the blue graph. Let's first look at the blue line. Can you see this blue line? Can you see this blue line? So this is a child who was short. He had a lag in the first year of life. He got a lag in the first year of life. And later during his adolescence, he could catch up. This is called constitutional short stature. Constitutional short stature. What is constitutional short stature? A child who is born normally, so he's born normal. Remember, constitutional is born normal. But he gets a lag at around 3 to 12 months of life. And later on, he can catch up. And he reaches the mean. Okay. So later in his life, he reaches the mean. So what would be his bone age if someone has to catch up? What will be the bone age in constitutional short stature? It will be delayed. So if in your question they ask bone age is delayed, that is constitutional short stature. But let's come to your question paper. Now in your question paper, they said this child is small. Now let's look at this red color line, all of you. Let's look at this red color line. I'll show you this red color line. The second line from below, this one. This child is शुरू से छोटा, small ही small, हमेशा small, less than -2 standard deviation, familial short stature. So familial short stature is small right from the beginning. He remains small. And he remains small. His parents are also small. So all of you in the class, if someone is supposed to be small, what will God do to his bone ossification? Chat box. Bone age will be normal. So remember, in familial short stature, parents are also small. Child is small right from the beginning. And bone age is equal to the chronological age. Okay. Remember, in growth hormone deficiency, one of the option, in hypothyroidism, one of the option, bone age is delayed. Okay. Let's go to the next question. The next question was also a straightforward question. What they asked was, they had a patient with fever and neck rigidity, and they showed a X-ray with hilar lymph node, and there was also X-ray on the upper lobe fibrosis. So there was upper lobe fibrosis, hilar lymph node. So you think about tubercular meningitis. Okay, so some of the students told me, I know everyone in the chat box, some of you told me that the CSF glucose was low. Of course, that's common in bacterial or tubercular meningitis. But what clinched the diagnosis in this question was X-ray findings. Remember, always, almost always, the primary is in the lungs. So if you have a child with hilar lymph node, upper lobe fibrosis, a longer history, 2 weeks or more, think about tubercular meningitis. Now there was a simple question, a child with pot belly, edema, you think about kwashiorkor because of deficiency of carbohydrates. So remember, in kwashiorkor, there is deficiency of carbohydrates and more of proteins. So it's more of deficiency of proteins. So there is edema, hypoalbuminemia, hepatomegaly, and pigmentary changes. So remember, kwashiorkor also has pigmentary changes, and we call them as flaky paint dermatosis. So it was a clear-cut case of kwashiorkor. Okay. Now there was a child with edema and ascites, and the child had effacement of podocytes. So remember, in the kidney, flattening of the foot processes of podocytes is seen in nephrotic syndrome. Okay, so there is proteinuria, hypoalbuminemia, hyperlipidemia in nephrotic syndrome. So remember, in nephrotic syndrome, there is proteinuria, hyperlipidemia, and hypoalbuminemia. And the most common cause of nephrotic syndrome in children is minimal chain disease. It was a straightforward question. You know, minimal chain disease has effacement of the foot processes of podocytes. Now, some of you told me, let me first take you to another question, another similar question. Some of you told me that there was another question on, let me ask you, a 20-year-old boy with edema, hematuria, RBC CAS. It is very common. I live in North India. I see a lot of children from Haryana, Rajasthan, Punjab who had a history of upper respiratory infection 1 to 2 weeks back, and now this child got edema, hematuria, and RBC CAS. They also have hypertension. This is called nephritic syndrome. Remember, edema, hematuria, okay, and hypertension is a nephritic syndrome. And the most common nephritic syndrome in the developing world is post-streptococcal glomerulonephritis. Okay, they have a history of URI 1 to 2 weeks back, or pyoderma, 4 to 6 weeks back. So a clear-cut case of post-infectious or post-streptococcal glomerulonephritis. Remember, C3 is low in these children. Okay. So coming back to another question, the question was, what is not true about ABCDE in pulse? Anyone? Of course, A is airway, B is breathing, C is circulation, but D is not dehydration. D is, anyone? Disability. So in pulse, D stands for disability. E stands for exposure. Okay, disability, exposure. Okay, so I hope all of you did very well, and I wish you all the very best. I'm Dr. Sidharth Sethi. You can tag me, you can message me on any of the social media platforms, whether it's Facebook, Insta, Twitter, or you can email me. And I wish you all the best. So on the behalf of DAMS family, all the best and see you on the other side. Thank you.